Hello everyone, I am Dr. Rohit Solanki. Today we are going to discuss one very interesting topic, ependymoma. So here we have non-astrocytic glial neoplasm. Under the entity non-astrocytic glial neoplasm, we have the mainly three tumors. First one is oligodendroglioma, ependymoma, and choroid plexus carcinoma. I am repeating it: oligodendroglioma, ependymoma, and choroid plexus carcinoma. Among these three, today we are more interested in the ependymoma. So, non-astrocytic glial neoplasm are divided into the oligodendroglioma, ependymomal tumor, and choroid plexus tumor. So today we are going to discuss the ependymomal tumor. So ependymomal tumor are the normal heterogeneous group of the tumor which arise anywhere in the neuroaxis. Here we can see that the tumor is arising from the supratentorial, also from the infratentorial location. It could be in the lateral horn of the frontal horn of the lateral ventricle, or at the level of the obex. So WHO has classified the ependymal tumor under the five entities. First one is most common is ependymoma. Second one is subependymoma. So most common is ependymoma. Second most common is subependymoma. Then myxopapillary ependymoma, Rela fusion, positive ependymoma, and anaplastic ependymoma. So WHO has classified the ependymal tumor under the ependymoma, subependymoma, myxopapillary ependymoma, Rela fusion positive ependymoma, and anaplastic ependymoma. So first of all, we will discuss most important ependymal tumor, that is ependymoma. So ependymoma could occur anywhere in our neuraxis. So 60% of the ependymomas occurs in the infratentorial location. In the infratentorial location, most of the tumor occurs, 90% of the tumors occurs in the intraventricular location, while few of them occurs in the intraparenchymal location. So most common is in infratentorial is most common intraventricular. And if we will talk precisely, this tumor is mainly arising from the floor of the fourth ventricle. 30 to 40% of the ependymoma arise in the supratentorial location. In the supratentorial location, mostly they are arising from the intraparenchymal. So don't confuse, just in the infratentorial location, more common in the intraventricular, while in the supratentorial location, more common in the intraparenchymal. And in the supratentorial location, they can occur, or they can arise from the lateral and the third ventricle. Rest of the 10% of this ependymal tumor or the ependymoma could arise from the spinal, and most commonly it arising from the conus or phylum terminally. So here we can see that the tumor in supratentorial location arising from the intraparenchymal, infratentorial arising in the floor of the fourth ventricle, and in spinal cord arising from phylum termini or the conus. So ependymoma has a two subtype. First one, here we can see that this said child of 3-year-old sitting so depressed. So EPF, EPNA and PF, EPNB. These are the two subtypes. PF, EPNA and PF, EPNB. PF, EPNA is occurring in the median age of the 3-year-old, mainly in the males. Patient or the child come with the complaint of ataxia and hydrocephalus. Here we can see that the 5-year survival of this child is only 50%. So PFEPNA is occurring in 3-year-old child, mainly in the boy, ataxia hydrocephalus, and 5-year survival is only 50% chances. While PFEPNB, this happy young man, so older children or the young age of the 30 year and 5-year survival is 85 to 90%. So here we have the two subtypes, PFEPNA and PFEPNB. Median of A is 3 years and survival of 50% is of 5-year survival, while PNEPNB survival is 85 to 90%. It occurs mainly in the older children or younger adult. So, gross pathology of ependymoma, it is well demarcated. This is the gross pathology. Here we can see that this is the well demarcated lobulated mass appear plastic. Plastic appearance, it means that it is behaving like toothpaste, like it is coming out of its tube. So when paste out of its tube, then it can spread or go anywhere wherever it get the space. In here, it is going in the foramen magnum by its Megendi and foramen Luschka at the CP angle. So it can cross the foramina Luschka and foramina Megendi and can feel the cisterns and encase the nerves and the blood vessels. So it is type of the encasing tumor which can grow to the foramen Megendi in the its cisterna magna and foramen Luschka, so at the CP angle. Calcification, cyst formation, and hemorrhages are common. So, grossly, we can see that it is a well defined lobulated mass lesion present mainly in the infratentorial. It could present in supratentorial location. Calcification, cyst formation, and hemorrhage are common, and it behaves like the plasticity or the toothpaste like. It can go anywhere wherever it gets the space. So, clinical issue. A young child, mainly a boy, will come to you with the ventricular obstruction. So, will give the complaint of headache, knuckle rigidity, nausea, vomiting, papilledema, diplopia, and all. So, if a child come with this complaint and mass is if mass is in the supratentorial, then the supratentorial symptoms like the ataxia, seizure, focal neurological deficit, this will be common. So, generally, a child will come to you with the complaint of the hydrocephalus. On imaging, we will get the well-delineated plastic tumor originating from the floor of the fourth ventricle as we discussed. Here we can see that this tumor is well-defined, round to oval lobulated, arising from the inferior cerebellum or the floor of the fourth ventricle. It extrudes through the outlet foramina. Here we can see that it is going in the CP angle, posterior it is going in the foramen megendi. Laterally through the foramen luschka, approaching toward the CP angle, and posterior-inferiorly the foramina megendi reaching to the cisterna magna. So obstructive hydrocephalus, because it's obstruct the pathway of the CSF flow, the lateral ventricle, third ventricle will be dilated, CSF will be oozing out, so blur image at the CSF oozing out, and in supratentorial it is usually bulky aggressive tumor, cyst, calcification, and hemorrhages are common in the supratentorial location. So on CT scan, like just we saw that one lesion which is well defined lobulated, cysts are there, calcification, gross calcification is there. So it will give the mixed density on the non-contrast CT. Hypodense intramural cyst, here we can see that this is our lesion where the focal calcifications are present. So it is hypodense intramural cyst could be there, iso to hyperdense soft tissue. So soft tissue is hypodense. Coarse calcification may present in 50% cases, and macroscopic hemorrhages could be there. Interestingly, on post-contrast study, it shows heterogeneous enhancement because of the enhancement in its solid component. Here we have the MRI. We can see that this is the T1 weighted image. Here it appears the heterogeneous hypointense, or this is our post contrast study of the T1 weighted image. Here we can see that it gives the heterogeneous enhancement. This is the T2 weighted image. Here we can see that it is appearing hyperintense, and post contrast study it is showing the homogeneous enhancement. So post contrast gives the heterogeneous enhancement or the homogeneous, depends on the consistency of the tissues. T1 it shows the heterogeneous hypointense, T2 it appears hyperintense as usual, and on DWIs do not show any restrictions. On MRS non-specific light it shows the increase in the choline and decrease in Na peak. Here we can see that it shows the plastic nature. So this is our mass lesion which is approaching toward the lateral recess and reaching up to the CP angle. Here is T2 weighted image. Here we can see that it is approaching toward the foramen of magna, and cyst reaching up to the foramen of megendi and reaching up to the cisterna magna. Here the T1 with contrast is showing the homogeneous advancement with our mass is reaching up to the CP angle. Here also we can see that the T1 with the contrast foramen luschka and foramen megendi, so reaching up to CP angle and cisterna magna. So broadly we can see that this is a plastic tumor with a multiple cystic or the calcified hemorrhagic condition with inside the tumor, and it's a solid component, shows heterogeneous enhancement of the post-caltonium study. This is the next case. Here a 3-year-old boy come with the complaint of the headache, ataxia, and vomiting or department. This is the photo from the Osborne. So here we can see that this is the flare image which shows the heterogeneous enhancement with the cystic in hypointense areas. This is here we can see that this is post contrast showing the heterogeneous enhancement. Also here we can see that on axial which shows the post contrast enhancement and reaching in the CP angle and foramen of Wegener to the Lushka and Megandy. So here is a 11-year-old female come with the history of the vomiting. So this is T2-weighted image. Here we can see that supratentorially this mass is showing the heterogeneous hyperintensity on HWI because of we already talked that there will be foci of the calcification so on and hemorrhage. So it shows the blooming, and on post contrast study it shows the peripheral enhancement, also the heterogeneous enhancement, and this is the perfusion. Here we can see that there is a decrease in the relatively blood flow. So, what will be the diagnosis or differential diagnosis if the mass present in the posterior fossa or a child come with the mass like this? So, there will be mainly three diagnoses or the differential diagnosis. First one is our ependymoma. Ependymoma, second one is pilocytic astrocytoma, and third one will be our medulloblastoma. So first we have to decide the most common location of this tumor. So our ependymoma will be present here in the fourth ventricle, mainly from the roof of the fourth ventricle, and it will goes to the foramen of Megandy and foramen of Lushka. While our pilocytic astrocytoma, here we can see that it is mainly the parenchymal tumor, mainly present in the posterior fossa of the child with a cystic lesion with intramural cyst within it. And our medulloblastoma mainly present in the roof of the fourth ventricle, usually present in the midline. So here we can see that it is mainly 85% chances that it will be in the midline, but it could present somewhere laterally or it could infiltrate into the parenchyma. So this is the location per se, the ependymoma, pilocytic astrocytoma and medulloblastoma. On T1, all of them will show the ISO2 hypointensity, but pilocytic astrocytoma interestingly will show the enhancement in its mural nodule. On T2 weighted image, they will show the heterogeneous hyperintensity because of its mixed relative will show the heterogeneous hypointensity, the heterogeneous hyperintensity. On post contrast study, interestingly, the ependymoma and the pilocytic astrocytoma will show the heterogeneous enhancement, while the pilocytic astrocytoma there will be a mural nodule which will show the strong homogeneous enhancement. In the medulloblastoma, we will have the either homogeneous or the heterogeneous enhancement. Calcification is more common in the ependymoma, but it could present rarely in the pilocytic astrocytoma and medulloblastoma. Hemorrhages are common in the ependymoma, but it could present in the pilocytic and medulloblastoma. Spread. So we have again and again saying that ependymoma is a plastic type of the tumor can spread through the like a toothpaste go into the Lushka or the Megandy, while the pilocytic is localized type of the tumor beautifully. It is inside a cystic lesion with a mural cyst within it present in the parenchyma. So it's a WHO grade 1 tumor. Whereas medulloblastoma is highly aggressive, it shows the drop mates or spread through the CSF. Age per se, this ependymoma occurs mainly in the children and young adult, while pilocytic astrocytoma approximately exclusively occurs in the our child, while the medulloblastoma primary occurs in the children. So this is the differential diagnosis of ependymoma, which is the pilocytic astrocytoma and the medulloblastoma. Now, we will discuss the second ependymal tumor, that is subependymoma. Subependymoma is like a incidental condition. So patient will not come to you because of that mass. Patient will come to you because of any other complaint. In 70 to 80% of cases, and incidentally we will get a mass well defined, smooth marginated. So it is a rare, benign and slow growing non-invasive tumor. So location per se, it is the most commonly present in the frontal horn of the lateral ventricle. 50% patient have the location of the frontal horn of the lateral ventricle, and it will be near somewhere in the foramen of Monro. So this is foramen of Monro location attached the frontal horn of lateral ventricle, subependymoma. Second most common is the fourth ventricle. So here we can see that the mass is present somewhere near to the fourth ventricle. Here also we can see that in the occipital horn of the lateral ventricle, mass will be there, and in this position the mass could infiltrate or invasive to the parenchyma. So subependymoma is a rare, benign, slow growing non-invasive tumor. Location per se, it is existent to the ependymal lining. So wherever in the body will be the ependymal lining, subependymoma could be there, but most commonly it will occurs in the frontal horn of the lateral ventricle. Second most common, the fourth and the Last, it will occur in the occipital horn of the lateral ventricle. So, gross pathology, as we discussed, this will be a beautifully solid mass, round to oval, lobulated, well delineated. If the size of the mass will be larger, then there will be chances that calcification, hemorrhage, and cystic changes will be common. Usually, it is a small in size, a solid round oval mass will be there clinically. As we discussed, that patient will not come to because of the subependymoma. It will come because of some any other condition, and incidentally we will get. So this a middle-aged young man will be come to you. Usually, it is common in the men which who will be asymptomatic because of the subependymoma, and incidentally we will get it. So management per se, there is no management for this condition. We have to wait and watch, and if the tumor grows aggressively or the size increase rapidly, so then we have to go for the surgery. So on imaging per se, there's a well demarcated nodular mass will be there. On CT scan, the iso to slightly hypodense mass with a few area of the calcification of cystic changes may be present or not present. Here we can see the hypodense mass present in the lateral horn of the frontal horn of the lateral ventricle. Here also the mass is attached to the pellucidii, and here we can see then post contrasted it shows the homogeneous enhancement. So this on MRI and T1, as we see that there is a hypo to iso-intense. On T2 it will show the heterogeneous hyperintensity, and GRE, if the calcification of the hemorrhage will be there, it will show the blooming. On flare, because of the existence surrounding tissue edema, the peritubular edema could be present or it could be absent. On DWI, it is not showing any restriction. So this is the MRI. This is the T1 weighted image. Here we can see that the subependymoma is present here at the fourth ventricle level. This is the axial of the T2, which is showing heterogeneous hyperintensity. On the flare imaging, it is showing the edematous changes with the heterogeneous hyperintensity. On contrast study, it is showing the heterogeneous enhancement. So this is all about the ependymal tumor. We have concluded all the ependymal tumors, with the most common is ependymoma and second most common is subependymoma. In next class, we will discuss the oligodendroglioma and the choroid plexus tumor. Thank you so much. Myself, Dr. Rohit Solanki. Thank you for watching this video. Kindly like, share, and subscribe my YouTube channel. Thank you.